Good evening, everyone. My name is Jen Nolan, and I'd like to welcome you to the 9th webinar in Move Muscle, Bone and Joint Health's 2017 Musculoskeletal Health webinar series. Today is World Arthritis Day, and it's appropriate that tonight's webinar is on the diagnosis and management of rheumatoid arthritis. We are very grateful to AbbVie Proprietary Limited for their sponsorship, which has allowed this important webinar to be offered free of charge to health professionals around Australia. A list showing the last 2 webinars for the year is on your screen now. We have a most interesting webinar in October about managing community expectations in relation to stem cell therapies, and another free webinar in November on the topic of psoriatic arthritis. Our presenter for this evening is Associate Professor Stephen Hall. Stephen trained in rheumatology at the Mayo Clinic. He has been in clinical practice since 1984 and is an Associate Professor of Medicine at Monash University based at Cabrini Health. He conducts a busy clinical practice and maintains a clinical trials unit. He has published widely in clinical trials in the fields of systematic lupus erythematosus, rheumatoid arthritis, polymyositis, ankylosing spondylitis, psoriatic arthritis, and osteoarthritis. Without further ado, I'll hand proceedings over to Stephen. Thanks very much, Stephen.
Thank you, Jen. Welcome, everybody. I'm Steve Hall. I'm basically in the business of seeing people with arthritis, and my concerns really about this that I was going to try to get across in this talk is what's new and what's old. The audience people out there, those of you listening, are people who've already evidenced an interest in musculoskeletal disease. And so I'm going to assume that you're actually quite knowledgeable and experienced. However, I think it's always useful to review some things and refresh our ideas of how we make a diagnosis, and then to move on to what things and what thoughts might have changed in recent years. So it's really about what's new and what's old. We know that we do careful literature review, but as this minister said, I turn to God for most answers, but occasionally I turn to Google, and heavens knows our clientele turns to Google very, very often. To be honest, a lot of the time in consultations, I also turn to Google and PubMed to try and answer questions. And of all the things that the IT changes in the last 20 years have given me, the most important one, I think, is Google Images, which allows me to really find pictures of things that people can see that they can identify with. This is somebody with a rheumatoid hand. Rheumatoid still looks like this when it's bad and when the disease is long-standing. What we're trying to do is to ensure that we don't have patients who look like this anymore. So what do our patients complain about? Because they still complain about the same things. The characteristic of an inflammatory arthritis like rheumatoid is that they're going to complain of pain. Fatigue is a major issue. But the thing which really characterizes an inflammation of the joints is this unique phenomenon of stiffness in the morning. This pattern of behavior where they wake up in the morning and they feel old. And then as they get going, have a hot shower, walk around for a bit, things start to improve. And we use that as a quantitative measure of what's going on. When I got into medicine, we all had to get in through getting maths and science. And the problem is that we never used our maths again. So this is the only time I get to use schoolboy mathematics. So we measure how severely active the disease is by the duration of morning stiffness. And the question that we ask is, what time do you get up? And you don't feel good then? No. And so what time do you feel as good as you're going to feel for the day? You may never feel perfect, but as good as you'll feel for the day. So they may say, I get up at 7, I feel as good as I'm going to feel for the day at 9, and here's where my schoolboy mathematics comes in. They have 2 hours of morning stiffness. The daytime equivalent of morning stiffness is what we refer to as gel phenomenon. This is the business where you sit on a couch and you watch TV, and then you stiffen up so that when you get up, it's hard to get around. That would be very characteristic of active rheumatoid arthritis. And all of that then leads to loss of function. So how do we make a clinical diagnosis? Because we'll make a clinical diagnosis more reliably than we'll use any other modality. Blood tests, I will warn you, will lead you wrong as often as they lead you right. So the first is to recognize that we do things clinically by pattern recognition, where we ask 4 questions. Firstly, is this inflammatory? Do they have morning stiffness and gel phenomena? And then when we examine them, we want to know, is there soft tissue swelling around the joints? If it's bony enlargement, it's osteoarthritis. If there's soft tissue swelling, that suggests an inflammatory arthritis like rheumatoid. Thirdly, we want to know, is it symmetrical? And that's a critical issue. And fourthly, we want to know whether there's other stuff going on. Because when rheumatoid first starts, there's not other stuff going on. There's not usually a rash or lung problems or blood vessel inflammation. If there is other stuff going on, then usually that means that there's another disease. It's likely to be in the setting in Australia in the summer months. If there's a rash and an arthritis, the chances are that you're dealing with a viral arthritis like Ross River fever or Barmer forest. If it's the rest of the year, that's when you wonder whether it's not a disease like lupus or a vasculitis. These are examples of symmetrical versus asymmetrical disease. So what we see here is we see on the left somebody who's got symmetrical disease. This is a very carefully constructed artistic representation over which I slaved for hours and hours. Shows that there's, if it's in one wrist, it's in the other wrist. If it's in one lot of metacarpophalangeal joints, it's in the other lot. If it's in one knee, it'll be in the other knee. If it's in one shoulder, the chances are it's the other. And if it's in one forefoot, it'll be in the other forefoot. And that we'll consider to be rheumatoid. It's symmetrical. When we see somebody like this homunculus on the right, where there's one wrist, one knee, one ankle, that's more likely to be a spondyloarthritis. And if you tune into to Marie Felletar's talk in 2 talks' time, she'll talk to you all about this, particularly if they've got this swollen toe, which would be typical of psoriatic arthritis. So what we have is inflammatory arthritis, where if it's symmetrical, we'll think of that as being rheumatoid. They've often, but certainly by no means always, have elevated inflammatory markers. And the tests we do are the rheumatoid factor and the CCP, or which is often known now as an ACPA. And these are tests which indicate potential severity of disease. That would be typical of somebody with aggressive rheumatoid. This is the hallmark physical finding. You can see here that what they have is where the pen is pointing, they have swelling around that second metacarpophalangeal joint. You can see the hollow in between the second and third metacarpophalangeal joints is filled out. When we want to know whether there's active synovitis, what we'll do is we'll look at which joints are affected. You can see here that there's swelling at the metacarpophalangeal joint, there's at the index finger, there's swelling at the middle finger, there's swelling at the ring finger, but the metacarpophalangeal joint of the ring finger is typically much less affected. And so if we want to know what's the baseline appearance and we feel it, I would often recommend that we start at the metacarpophalangeal joint of the ring finger and then work out to the other joints. That way you know what's normal for that person. This would be somebody who's a young person who's got a typical inflammatory arthritis, which in this case primarily affects the proximal interphalangeal joints. People have come up with criteria for rheumatoid arthritis, and as you can see, the criteria add more points if you've got 10 swollen joints, and so we're looking for 6 points to make a diagnosis. So if somebody's got one joint, they don't rack up any points at all, because that's not typical of rheumatoid. If they've got more than 10 joints, there's at least one small joint, that's very typical of rheumatoid. You can see that if either test the rheumatoid factor or the ACPA, the CCP antibody, is positive, you rack up 2 points, and if it's high titer, you rack up 3. And there's a reason for doing one or the other, because while most people with a positive rheumatoid factor will have a positive CCP antibody or ACPA, there'll be people who have positive CCP, normal rheumatoid, people who have positive rheumatoid, negative CCP. We're looking for duration of disease of at least 6 weeks, and we're looking for acute phase reactants. So you can see that the ESR and CRP only racks up 1 point. So we don't see that as being as fundamental to the diagnosis. I know that frequently people say, well, disease can't be active. It really will only be, you've got to reflect the activity in the joints. And that's not true. At this point, my patients usually ask me, so what caused this to happen, doctor? Why have I got this? Surely there's got to be a reason. And we know that the traditional advice is that we go back to Greek, and we call this idiopathic, which I often propose is derived from the words idios and pathos, which means many idiots make pathetic attempts at an explanation. And at that point, I usually confess that we have no idea. But we've got a better idea now. We know there's a genetic predisposition. On the right, what you can see is the HLA, the immune gene area. And what you can see is that it looks like several coils. And in the middle, that's where antigens get put to be processed. The HLA genes that are associated with rheumatoid are really HLA-DR4 and HLA-DR1. There are a number of different gene types, HLA-A, B, C, and then the D-related genes. And doctors are not that imaginative, so we call them 1, 2, 3. With HLA-DR4 and DR1, there's a small amino acid segment which is illustrated on the table C, which you can see, where you can see that there is, in the various sequences, the areas that are, the genes that are associated with rheumatoid arthritis have this small sequence between the 70th and 75th amino acid, which look remarkably similar. And that small sequence is known as an epitope, and it's shared across a number of genes. So we refer to that as a shared epitope. And we have 2 copies of every gene. So what we found was that if you have a double dose of the shared epitope, then you're far more likely to develop rheumatoid arthritis. So genes play a major role. Now this is maps of the United States, and we can see that in this top corner here is Minnesota. And then we can see that within Minnesota there is Olmsted County, just down here. And what happens, why is Olmsted County important? Because there are a number of healthcare providers, but they have a centralized record system. And that record system goes back some 70 years. And all of the records can be screened centrally from every nursing home, from the few private practitioners, from the regional hospitals, from the Mayo Clinic, and from a couple of other groups, such as the Olmsted Medical Group, and they share their record system. So that means that what we have is a population of about 130,000 people who've been effectively prospectively followed with really high quality medical care and excellent clinical records for a long, long time. And we can find out lots from that particular resource. What we found in terms of the incidence of rheumatoid arthritis was that the incidence, both in men in red and in women in red and men in yellow, declined between the 1950s and the early and round into the early part of the 1990s. So we used to think that rheumatoid was on the decline, and that looked very encouraging. What we then found was that rheumatoid's gone up, particularly in women, and it's gone up quite dramatically. And that increase in the incidence into the number of new cases of rheumatoid is absolutely related to the amount of obesity in the female population. It really closely relates to BMI. In the earlier period, only 13% were obese. By the time we get into the mid-2000s, we're finding that even in this wealthy community, and Olmsted County is per capita quite a wealthy community, even in that wealthy community, obesity is present in almost 50% of people. Very much relates to that factor. So obesity's come to be recognized as a major factor contributing to the development of rheumatoid arthritis. We know that smoking is a bad thing. We tell our patients not to smoke, but it's not until fairly recently that we've come to recognize that the risk of smoking extends into the risk of development, risks from smoking extend into the development of rheumatoid arthritis. If we look in these graphs here and we take never smokers in the grey and ever smokers in the dark, if we look in the CCP positive rheumatoid population, what you can see is if you have no shared epitope, there's not a lot of difference. A little bit more if you've got a single copy of the shared epitope. Ever smokers have an increased rate compared to never smokers. And then if you look at people who've got a double dose of the shared epitope, in other words, one copy on each gene contains that shared epitope, not only has the risk of rheumatoid gone up in never smokers, but the risk of rheumatoid has gone up astronomically in people who've ever smoked. In contrast, if you're CCP negative, that relationship doesn't exist. So here is an interaction between something in the environment, smoking, and something that you inherit, your genetics. So we know that smoking increases your risk of rheumatoid. Heavy smoking increases the risk of rheumatoid by up to 100%. Smoking lessens, and persistence in smoking compromises the effect of treatment. If you're a smoker, your rheumatoid's more likely to be severe than a non-smoker. And the thing that you can do that's best for you to control your rheumatoid is to give up cigarettes. We also know, with respect to obesity, that if you lose 5 to 10% of your body weight, you'll enhance the effectiveness of the treatment that's prescribed. So there are environmental things that patients can do to help themselves. So this gene-environment interaction is really fundamental. And this is a synergy between your genes and your cigarette smoking. The hottest topic in medicine now is the microbiome, the concept that gut within the organisms within our body that are not part of us influences how our body functions. We normally think of the microbiome as being the gut microbiome, and that's where it was first studied. In rheumatoid, the gut doesn't seem to be very important. The teeth are important. Periodontal disease is strongly associated with the development of rheumatoid arthritis. And when one looks here at that membrane where the tooth inserts into the gum, the periodontal membrane, what we find under the microscope is that that membrane looks astonishingly like synovium. And if there's a lot of periodontitis, we see that it looks very much like rheumatoid synovium. So morphologically, there's similarity. What we found is that there are organisms, such as this organism, gingivalis, which produces enzymes, and that has an effect on citrulation of peptides. Citrulation is a word that I haven't used so far, but I've inferred it, because CCP antibody, the other confirmatory test for rheumatoid, stands for cyclic citrullinated protein. Citrullunation is a chemical reaction that develops in proteins after they've been made. So it's an after-the-fact change in the protein. And when the proteins get citrullinated, we lose tolerance. You recall that Macfarlane Burnett from the Walter and Eliza Hall in Melbourne won the Nobel Prize for introducing the concept of immunological tolerance. That is, we recognize what is us and what is not us, what is self, what is not self. And we kill what's not self or react to it, and we tolerate what is self, a little bit like families. And what we know is that if you lose tolerance to the antibody, to proteins, then those proteins can stimulate inflammation. That is the epigenetic concept. And here we are, and epigenetics is big time, and it's available out there for you to set up commercially and call yourself a healing center and be an epigenetic center. Remarkable thing that there's always an entrepreneur out there prepared to prey on people who've got problems. So what we have in this slide, we see that there are risk alleles on the left, environmental exposure, in this case cigarettes, which then changes peptides, and that initiates immune events. And if you've got an asymptomatic CCP or ACPA positive person, it will trigger rheumatoid, give you joint pain, bone loss, and you end up with this ACPA positive or seropositive rheumatoid arthritis. So this is fundamental that we have a genetic predisposition with HLA-DR4. Within that predisposition, we've identified a 5 amino acid segment that reflects the risk. We found that the more copies of that, you can only get 2 copies. So if you've got 2 copies of that gene, you have a double dose of the shared epitope, you're far more likely. We found that that interacts with obesity, and it interacts with cigarette smoking to dramatically increase the risk. And it interacts with internal organisms, particularly in the teeth. So we have this story that's emerging of what we are born with and what we're exposed to, resulting in a disease. This is another more involved slide that talks about the mechanisms of loss of tolerance, emphasizing this epigenetic modification, which produces post-translational modifications of proteins. We're familiar, I've outlined citrullination, but you can see that there are a number of other ways that proteins can be modified. Citrullination seems important in rheumatoid factor positive disease. Carbamylation, another post-translational modification of the protein, is important in seronegative disease. And that then ends up feeding into this clinical picture of this person who you can see has got, and I'm trying to work out this, this whole very complex video, and so this around these proximal interphalangeal joints. So environmental factors, periodontists, smoking, epigenetic modification, and that then leads on to disease. So what happens in this? How common is it? It's about 0.5 to 1% of the population are affected by rheumatoid. So it's not rare. What we have here is a picture of what happens when you look inside, in this case inside a knee, and you see that you've got the bone and the cartilage, and then you start to see this capillary formation, blood vessels growing in to the joint, and then becoming quite thickened. And all of that's terribly interesting. And we see radial deviation, these characteristic deformities of rheumatoid that we would hope now we never see anymore. Someone comes to us today with new onset rheumatoid arthritis, you would hope that with exposure to the treatments that we've got available, that these changes will never, ever happen again. And what we're seeing here is people who've gone here, a normal joint, and here you can see the space between the bones has narrowed, which means there's cartilage loss. And here you can see it looks like something's taking a chunk out of the bone, and that represents erosive change. What we don't want is this transition with loss of cartilage and bone damage, which represents irreversible change. By the time there are changes on plain X-ray, those changes cannot be reversed. So the emphasis now has to be on trying to get people early and having them on aggressive treatment capable of preventing changes, but at the same time minimizing the risks of treatment. So how do we tell who needs what treatment? And we can risk stratify. In other words, we can see somebody who's got a clinical picture of rheumatoid, a symmetrical arthritis with stiffness in the morning, gel phenomenon and soft tissue swelling. We say that looks like rheumatoid, and then we go on to do further tests, and such as rheumatoid factor and CCP antibody. If those tests are positive in high titer, that's going to be an important factor predicting that there will be joint damage. And that person needs to be treated aggressively. What we know with near certainty is that somebody who has seropositive rheumatoid arthritis is never going to go into remission. They will always have active disease, and left untreated, they've probably got an 80% chance of progressing to severe joint damage. We know that people who respond to mild treatments, like anti-inflammatory drugs, probably have pretty mild disease. If they're all better, put somebody on an anti-inflammatory drug and they no longer have any inflammation around their joint, they no longer have any symptoms, they no longer have any swelling around the joint, the chances are that person's never going to go on to get damage. So they don't need necessarily to be treated with the same degree of aggression. And imaging is another way that we can employ to get a better handle on who should be treated more aggressively, since most people don't want to be treated aggressively. This is a picture of somebody having an ultrasound of the joint. An ultrasound is increasingly used as a way of identifying whether there's swelling in the joint, whether the disease is active. This is an example of somebody with metacarpophalangeal joint synovitis. And what we see on the grayscale is very operator dependent. The grayscale is the usual ultrasound, where it's basically in black and white and different shades of grey. But when we bounce sound waves off the high frequency sound waves in a Doppler signal, we can see blood vessels and blood flow in particular. We're used to doing that, a Doppler study for venous disease to diagnose deep venous thrombosis. What we see here is all of this bright red signal, or sometimes a bright blue signal, which would indicate that there's marked blood flow. And that's a very important sign. That's a more reliable sign. This here is a more reliable sign of active rheumatoid disease than is the grayscale. That's far more operator dependent. And what happens with treatment? Well, we see this is before low-dose steroids. And so you look at this and you say, okay, well, here there's power Doppler signal in a couple of different joints. You see here's a bit of red, and here's yellow, and it's ferociously angry, and there's lots of increased blood flow, and then they get put on steroids. And remarkably, steroids, which are so good at getting rid of the symptoms and signs of rheumatoid, get rid of the increased blood flow. So they will suppress it. What we're looking for is for disease inactivity. To be sure that disease is inactive, we're looking for very little in the way of this power Doppler signal. Problems with ultrasound are that it's very operator dependent. You're absolutely dependent on the competence of the person using it. For those of us who order ultrasounds, use our local radiology department, I'm yet to find a radiology department that doesn't say, we've got a really good ultrasonographer. We've got a fabulous ultrasonographer. And because nobody ever says, you know, our ultrasound is rubbish. And yet there are tremendous differences between the quality of ultrasound. And that relates to the quality of the transducer, the quality of the ultrasound technician. These are important things. The specific feature is not the thickening, but rather this power Doppler signal. No power Doppler signal equals no evidence of active synovitis. How reliable is that? Well, it does help us tell whether the disease is active or inactive, and at times that can be challenging. How reliable? Furthermore, we've looked at people who've had very early joint inflammation, where it was too early to meet the criteria that I showed you for rheumatoid. But those people who had a positive power Doppler signal, they will usually go on to develop rheumatoid arthritis. A negative power Doppler signal, not so reliable, doesn't exclude it totally. This is the alternative way of looking at it, and this is an MRI. MRIs are beautiful. We all, rheumatologists love MRIs because we can have a look at them and we know what's going on. What you can see is these bones and then all this white stuff. And you can tell that it's bad because you've got arrows pointing at it. For people who like Renaissance painting, Saint Sebastian is frequently shown with arrows and spears through him, usually with a sort of beatific smile. And I always think this is like the Saint Sebastian's sign where you've got lots of arrows, where the radiologist has drawn our attention to the fact that there are abnormalities. All of this white stuff that you can see, like here, that white stuff, and in there, that's all very abnormal, and that would suggest active synovitis. But we see more than that, because we can see these areas here. Do you see that? And there's some other areas in here where there's white inside the bone. And that's what we call bone edema. And bone edema is a very strong predictor that a person will develop joint damage. So here we see a joint in A, we see a normal joint. In the B, we see what we call fat suppressed. You can see all the bones are black because we got rid of the fat signal. And there you see a strongly positive St. Sebastian sign with an arrow pointing at white, which always is bad. See the white around the bones, that's active inflammation. In C, we've got this circle around, and you can see little bits of white within the bone. And that tells us that joint is going to go on and get erosions. And in D, you can see they've circled where there are erosions, little holes in the bone where there's loss of continuity. Like there. And there, where you can see that there is a break in the black line around the joint and a hole there. That is never a good sign. That is damage. And we will see damage an average of 2 years earlier on MRI than we will on plain ultrasound. And for that reason, we see MRI as being useful in predicting the future in people who've got normal x-rays. If they've got abnormal x-rays, there's no point in doing an MRI. You already have your answer. They have erosive change. But if you've got normal x-rays, then an MRI may have real information to guide doctors in how aggressively you should treat them. So how do we treat them? Typically, step one is anti-inflammatory drugs, exercises, for many people, cortisone, steroids, and complementary therapies. It's fair to say that most doctors don't initiate much in the way of complementary therapies, and it's also fair to say that most patients explore them. Fish oil supplements, curcumin, turmeric, glucosamine, chondroitin, a variety of things, traditional Chinese medicine, naturopathic dietary exclusions. I'd love to say they were terrific. Fish oil has some merit, but the amount of fish oil you have to use is substantial. The current recommendations are between 14 and 24 fish oil capsules a day. You tell that to people and their eyes start rolling. And so probably 15 mils of fish oil concentrate, the liquid fish oil concentrate, which doesn't taste so gorgeous. That is really the dose that you need. Step two in clinical practice is often steroids. And steroids are widely used, particularly in general practice, because they work so quickly. You saw what they did on the ultrasound. They reversed the symptoms and signs. You have a very happy patient initially. The problem is over the longer term, and we are interested in the longer term with our patients. The problem with the longer term is the toxicity of steroids, and we often underrate the severity of that toxicity. Even 5 milligrams of prednisolone a day, which is generally thought of as a small dose, doubles your risk of being admitted to hospital with infection. It is the most infectious producing agent we have. And then if you fail step 1 and 2, you go to conventional DMARDs, which are disease-modifying anti-rheumatic drugs. Methotrexate, which is the one most commonly prescribed, hydroxychloroquine, sulfasalazine, and leflunomide. And then if you don't respond to those, you go on to biological drugs, which are really important. These are the EULAR recommendations. We come up with recommendations and guidelines for how we get treated, and what they've said is a clinical diagnosis of rheumatoid, and if methotrexate is not contraindicated, you start methotrexate. And you combine it perhaps with short-term steroids, or you start with leflunomide and cilazoparin, And if you're not better within a specified period of time, you go on to more aggressive treatment. And particularly if you've got these prognostically unfavourable factors, things like rheumatoid factor and early joint damage, the type of things that I was talking about in terms of risk stratification, then you would go on to more aggressive treatment. So what do we use in practice in Australia? OPAL is an Australian observational database derived from private practice. It's enormous. In 2013, there were 5,500 patients on that database. Today, there's 28 to 30,000 patients. The most common disease-modifying drugs that we used, you can see, were methotrexate, 73%, flunomide, 19%, but 28% of our rheumatoid patients were on steroids. Is that a great thing? It's probably sometimes forced upon us, but it's not an ideal thing. You increase the risk of infection, you increase the risk of osteoporosis, you increase the risk of glaucoma, of cataracts, you put on weight, you make thin skin, you give them easy bruising, you bring on diabetes, aggravate blood pressure. This is really, really a dangerous drug, and more dangerous than anything else we use. So it would be my general recommendation that we try and use other drugs to allow them to come off steroids, even if we had to use some prednisolone in the first instance to keep things under control. What happens to these people? Well, their functional state improves. If you give them leflunomide or methotrexate, and in this study what we saw was this, if you go down, that means an improvement in your quality of life. So this was the modified HAC, and you have a look at it. It's a health assessment questionnaire. Some doctors use it routinely, and so what we see is that leflunomide and methotrexate improved it, and the placebo patients deteriorated. With another form, if we look at this other form of health assessment questionnaire, the placebo group, which is the little red bar here, minimally worsened. But the methotrexate and the leflunomide group got a lot better. The bars went right down. So what that tells us is that disease-modifying drugs, such as celazopirin, methotrexate, leflunomide, will improve our patients' quality of life. How does methotrexate work? Well, methotrexate's often, people are often told, this is an anti-cancer drug. Very severe anti-cancer drug, except that the cancer doctors use 50 to 100 times the dose. So the high doses that they employ and the low doses that rheumatologists employ make them two very, very different beasts. And encouraging the thought that this is an anti-cancer drug is usually pretty counterproductive. What we do know is that in high doses, excuse me for one moment, in high doses, like in cancer therapy, the drug works by stopping cells using folic acid. You'll recall that folic acid is the vitamin that women take in pregnancy. And that vitamin is important for cell division. And so the cancer cells are dividing faster than normal cells, so you block their ability to use folic acid, and the idea is you kill those cells much more than you kill normal cells. And so we want in high doses to inhibit folic acid and stop cells dividing. In low doses, such as we use in rheumatoid, folic acid supplements, it's almost certain that the mechanism of use of methotrexate is quite different. It probably doesn't depend on folic acid at all. However, the side effect profile does. So that means that we can give folic acid, prevent the side effects of methotrexate, and not in any way interfere with its ability to work. So people often say, well, we give folic acid once a week, we give it twice a week, we give folic acid 5 times a week. Many people say 6 times a week, but not the day that you take methotrexate. And I think there's very little data to support those views. I think the more folic acid you take, the better you tolerate the drug. We're really not clear on how much is optimal. What we do know is that if you take at least 1 milligram of folic acid a day on average, or you take folinic acid, which is the activated form, much more expensive, rarely prescribed for that reason, you reduce toxicity. We know that if you take folic acid, you reduce the amount of abnormal liver function tests, but lots of people stop their folic acid and they need to continue to be reminded about it. We worry a little bit about methotrexate in the liver, but it looks like methotrexate by itself probably doesn't cause the problem. It really enhances the effect of alcohol. And our treatment recommendations with respect to how much alcohol you can have changed in recent times. We now think you could have 14 standard drinks a week, which is 2 standard drinks a day on average. It's actually more than the NH and MRC guidelines recommend, but it's not more than many of my patients are taking. We know that abnormal liver function tests are not a good guide, and now there are new techniques which we use to assess liver toxicity from methotrexate. There's a thing called transient elastography, or a fibroscan, and that's been a very useful test that's used when we have a question mark about whether there's fibrosis or scarring in the liver. Do our patients like methotrexate? Rheumatologists love it. Methotrexate is the drug that changed the world. We no longer put people in wheelchairs courtesy of methotrexate. Methotrexate led to a 70% reduction in the amount of orthopedic surgery that was employed. We love methotrexate, but the question is, do our patients love it? And the answer is no. When we did a survey of a large number of patients, 40% would prefer not to continue, even though most of them knew it was important for their health. And so we need to share the decision-making with our patients. And shared decision-making is compromised. That's a problem. How do you share the decision-making when they don't trust the doctor, when they don't understand what they're reading, or when they're older, where they're deeply suspicious of new things? And we know that methotrexate persistence varies incredibly widely. Some people report it in 25%, some people in only in 85%. It's really variable. So what we do know here is that inside the rheumatoid joint, there's a lot of stuff going on. You can see that what I've tried to show here is that you've got these chemicals here which are driving the process. And then they're producing all sorts of other chemicals, interleukin-1, interleukin-6, tumor necrosis factor, and they all have effects on not only in the joint, but in the circulation itself. They'll increase bone damage. They will increase osteoporosis. They'll produce high inflammatory markers. And so we've developed antibodies, the biological drugs, that will block those chemicals. And they are dramatic. If we look here, excuse me, if we look here at what happens, we see the total sharp score, which is a measure of damage. And we look at people changing from the initial benefit. And so what we see is that there's less radiological progression in this group if they've been on etanercept, on one of the biological drugs, compared to methotrexate. This is fundamental. You can see a big difference in the erosion score and the methotrexate score. Sadly, I've misplaced the way that they've been labelled. So really, it's the protection is there with etanercept much more than methotrexate. So then the question is, if these drugs are so miraculous, and many of you will have seen patients who have been on biological drugs like etanercept, like adalimumab, which is Humira, like infliximab, which is Remicade, like Actemra, which is tocilizumab, Orencia, which is abatacept, rituximab, which is Mabthera. All of these various treatments are now new oral therapies like Xeljanz, which is the first of what will be a family of drugs of JAK inhibitors. All of those drugs work and protect you from damage. So the question arises, why don't we use biological drugs on everybody? We know that these drugs will block TNF signaling pathways. They will do nice things to protect and fancy things to protect it. So we have these drugs which are referred to as biological drugs. But the reason they're referred to, biological drugs is really bizarre, isn't it, as a term? Biological drugs refers to the way they're manufactured. Almost all the drugs that we ever use are made in chemical factories by chemical processes. Biological drugs are made by living cells in tissue culture, which have been genetically modified to make these antibody treatments. They're not made in little laboratories where you come out with powders and chemicals. Rather, they're made in things that look like small wheat silos. And these cells then produce a stew of chemicals, but they're made to make one chemical in particular, which is whatever they're programmed, whether it's an anti-TNF or an anti-IL-6. And those drugs are called biological drugs, which refers to their manufacturing process. They are all large protein molecules, and they share one important feature, which is that as a large protein molecule, you can't swallow it. If you swallow it, your stomach will think it's like any other large protein, like a piece of meat, and it will digest it. So they have to be given by injections. This is what happens when you treat people who've never been on methotrexate, and you compare infliximab here to methotrexate. And what happens here is that the methotrexate group and the infliximab group, or the methotrexate group and the adalimumab group, or the methotrexate group and the golimumab group, did pretty much the same. But if you look at people who are methotrexate non-responders, you see a major advantage in the treatment response for being on a biological. So there's no sense in giving these drugs to people who responded to methotrexate. This is the family of biological drugs that we have now. We have etanercept, Humira, Remicade, Cimzia, Simponi, we have Orencia, Actemra, rituximab, and we have the new JAK inhibitor, which is known as Xeljanz. How well do they work? They all work about the same as each other. They all work pretty much the same. There's no big difference in treatment response. Do they improve your quality of life? Yeah. This is, remember, down is improvement. And what you can see in this study, where people received Actemra, an antibody to IL-6, that they got better within a week, and by 24 weeks they were dramatically better. So there is improvement which happens very early in quality of life. There is improvement in terms of joint scores. So what we see is the methotrexate group. This is progression of damage, getting much worse, whereas if you're on Humira, you don't get any damage at all. In fact, you don't even have to get improvement in your symptoms and signs. Once you're on these drugs, you don't get damage. They protect you profoundly. But it's not just the joints that are the issue, because what we know is that people with rheumatoid arthritis have an increased cardiovascular risk. And for rheumatoid factor positive disease, that increased cardiovascular risk is equivalent to insulin-dependent diabetes. So what we find with these drugs is that you reduce the rate of heart attacks dramatically with drugs like methotrexate and TNF inhibitors. Now what we've got is these are people who've had a stent, and we put them on, this is rheumatoid and not rheumatoid, so you see here the rheumatoid patients much more likely to get cardiac disease. And then if you put a stent in them, in people with rheumatoid, so you want to see what happened to this really high-risk group. If they had no methotrexate, that was their survival, and if they were on methotrexate or a TNF inhibitor, their survival was dramatically better. So the use of aggressive treatments for rheumatoid is helpful not only for the disease, but also for cardiac problems. This is our model of really bad disease that we hope to never see anymore. So what we can conclude is that the symptoms and signs of rheumatoid haven't changed since I went to medical school 40 years ago. There has been a resurgence of rheumatoid driven by obesity and smoking and dental issues. That we've got new imaging techniques that allow us to more accurately tell whether the disease is active and to give a guess as to what the future has to offer. We know that if you treat earlier, you do much better. I would stress that steroids, cortisone, prednisolone, is incredibly dangerous, and other drugs are thoroughly justified if they can bring down the steroid dose. That methotrexate and other drugs that control the disease prevent damage by the disease, they improve quality of life, they dramatically protect against vascular disease. And so a drug that makes you feel better, that makes you protects you from damage requiring surgery and makes you live longer can scarcely be seen as being a bad thing. And biologics are extraordinarily good when methotrexate is no longer achieving the goal. Now we have a number, that's the end of my presentation, but we have a number of questions. One from Michelle G. Does rheumatoid typically affect metacarpophalangeal joints and metatarsophalangeal joints concurrently? Typically it starts in the feet at the metatarsophalangeal joints, but the thing that brings you to the doctor is your hands, the metacarpophalangeal joints. So usually it'll start feet first and then move to the hands. But it's the hands that people complain about when they first go to see the doctor. The risk factors, how much do the risk factors from Joanne L., how much of the risk factors explain the overall incidence of rheumatoid? Probably they explain, for seropositive disease, they probably explain about 50%. For seronegative disease, obesity probably explains quite a deal. The degree of explanation for periodontal disease, while we recognise it, hasn't been nearly as well studied, and the jury is out. But it does seem fairly clear that cleaning your teeth is not enough in the way of reversing that process. Maggie T asks, what's the outlook for those who are severe and treatment resistant? The outlook depends on what you have. It's very rare now to see treatment resistant disease. With the advent of the biological drugs, we can get almost everybody under control one way or another. But we are looking constantly for new treatments. Beyond the drugs that we have now, we have a variety of other drugs in trial that work through different mechanisms. Different JAK inhibitors, there's a family of oral drugs that work on B cells, which is a different cell type that's involved in rheumatoid. We will shortly be starting a trial where we will insert a stimulator in the vagus nerve in the neck, just around here, about the size of an antibiotic capsule. And that has been suggested in very small studies that might switch off rheumatoid without medication. An exciting prospect. Maggie T asks, should all patients with suspected rheumatoid be seen by a rheumatologist? Without wishing to drum up business, I think they must. They must, if only so that we can predict what their future is likely to be and work out whether they need to be on aggressive treatment or less aggressive treatment. And if they need to be on aggressive treatment, they really should be seeing their rheumatologist. Unless their primary care physician is prepared and incapable of assessing the joints very accurately with regular physical examination, then you really have to be seeing a rheumatologist. What's the evidence that physical activity is valuable in reducing the severity of arthritis, and what type of physical activity? The issue there is physical activity probably doesn't have a lot of evidence showing it reduces activity of disease. There is some evidence for water-based therapies that they will be helpful, but the critical thing with the physical activity is not so much its effect on the degree of inflammation, but on a person's ability to function. So they will maximize function. And so what we want to do is use medication to control disease activity and physical activity so that we get the best possible value out of our body. Stress and mental illness. Stress, I think, is the great magnifier. The role of stress is really, every clinician sees that as a significant issue. Quantifying it, however, is really difficult. In terms of mental illness, that gets really interesting because bipolar disease is said to be associated with rheumatoid, but schizophrenia is actually said to protect people from developing rheumatoid. It's actually pretty rare to see somebody who has both seropositive rheumatoid arthritis and schizophrenia. Physiotherapy in terms of centrality of treatment is really not as central as it used to be. If we treat the disease and we get them all better with drug therapy, then most people feel their need for other ancillary therapies becomes much less. The person who's been allowed to get joint damage is going to rely on physiotherapy a great deal more. The question is, do you have to have a history of other drugs like methotrexate before you can go on biological treatment? Absolutely. You have to have been on methotrexate at the time of making application. to get access to biological drugs under the current PBS guidelines. Young women in pregnancy, I approve. Kate M asked, what about young women in pregnancy? The question is, what drugs can you take when you're pregnant? And steroids you can take in pregnancy. You can take anti-inflammatory drugs for the first 3 months of pregnancy. You can't take methotrexate. You can't take leflunomide. You can take sulfasalazine. You can take hydroxychloroquine. And you probably can take TNF inhibitors. Having said that, most young women don't want to be on any drugs when they're pregnant. Now it is 8 o'clock, and we are under strict instructions that we finish at 8.
That's right. So, Steve, is there a question just in those last couple that you would be happy to answer just before we wrap up? You know, it's sort of, I suppose people who got in early with their questions have certainly had them answered. Is there just one there that you would choose to finish up on?
Okay, is there a research study about the use of cough syrup for the side effects of methotrexate? Cough syrup has been used to reduce the toxicity of methotrexate, particularly in the pediatric population. And when somebody has terrible nausea, coupling it with cough syrup will actually make a real difference. And children with rheumatoid absolutely need to start with aggressive therapy, and they should be under a pediatric rheumatologist, and you do not want them on steroids because it will inhibit their growth. And are there dietary factors that aggravate rheumatoid? Probably not any growth. And are there dietary on any consistent basis that I could recommend it and consume or avoid it? And by all means, you can crack your knuckles. It'll just disgust everybody around you, but it won't cause rheumatoid.
Well, look, on that note, and I can see a few comments coming through, it was truly a great presentation, so comprehensive and so clear. So thank you so much, Steve. Thank you, everyone, for joining the webinar tonight. Can I remind you about the couple of webinars we've got left for the rest of the year, one in a week or so on stem cell therapy and what you should explain to your patients, and also another free webinar in November on psoriatic arthritis. So we'll be in touch about those. But once again, Steve, thanks so much. And to everyone else, good night.
My pleasure. Thank you very much.